Clinical audit. So, if you see the definition, is a systematic and clinical analysis of the quality of clinical care. So that means, there are procedures, there are things to follow when we are provision of the care, when we do the clinical assessment, and even the treatment. During the treatment, just like when the follow up the patient, assess the bacterial clearance, Staphylococcus aureus or MRSA bacteremia clearance, Candidemia clearance, or maybe use of aspirins with the patients with myocardial infarction. So there are procedures and things to follow to provide the proper patient care. There are a lot of templates being made for assess the procedure accuracy. Likewise, there are things. So here, what we do is, there are guidelines, standard operation procedures has been laid by different institute sectors for that particular procedure or process. So, and what we do is, what is the current practice? How they do it? How they follow it? And we compare it with the guideline. That is the benchmark. That is the proper benchmark practice. And what are we practicing at the moment? And we see, is there any severe major differences? And if there are some differences, we introduce that into the existing practice to make it much more appealing and much more efficient and versatile. Then we allow it to follow and we do again an audit. It's termed as re-audit. See whether they are doing or not following that novel implementation while assuring the previous existing practice as per the guideline. So once deficiency been addressed, then we allow some time and reassess, re-audit and see whether it is happening. Likewise, it's audit cycle and spiral like it's going on. With the idea is improve the quality of clinical care. So it is under the arm of clinical governance. The clinical governance is the whole idea is improving the standards. So you can see there are 7 pillars of clinical governance. Clinical audit is one. Clinical effectiveness, risk management, and of information, education and training, staff, management, patient, public involvement. So clinical audit is one of 7 pillars of clinical governance. So clinical governance, you have to have an idea. When you are doing postgraduates, just get an idea. Keep this as an initial learning point about the clinical governance. And under that, we will go ahead with the clinical audit. So that also applicable at this, not at usually in the undergraduate level, but when it becomes postgraduates and so on, it will be helpful. So why we are doing critical analysis of your own skills and ways of working. Critical look at the system that delivers care to your patients can make a real difference and change things for betterment. So, what should be happening? What is happening? What should be happening is benchmark or guideline. What is happening is current, what they are doing. What changes are required? Then we have to apply and pre-check. So, audit is not to data collection its own shape, cost cutting exercise, a piece of research study. It's not as such. Then what is it? So you can compare with the clinical research and clinical audit. Purpose, clinical research is adding the knowledge to existing knowledge. So here it is proof of the hypothesis. So I think you have started your research in medicine module, so you may have some idea. Clinical audit is actually for the improvement. Here, scientific inquiry. It is systematic measurement. Function like set standard, here compares the standards. Sample size, statistical significance, there are samples for that. Here, commitment to act, sorry. Basis for measurement, testing the hypothesis. This will happen or not. Here it is standards of practice. Method is new treatment. Here, no new treatment. Likewise, I can't see this. What has happened? So here, improve the practice. That's how it goes. So this is a real audit cycle. Select a topic, observe the current practice, what is happening, compare with the standards, implement change, then allow some time and re-audit. So wonder whether what is this? One example is if we go with in microbiology, hand hygiene. You know hand hygiene. Before touching the patient, after touching the patient, before any specific invasive procedures. Likewise, we need to follow the hand hygiene. That is, we need to use skin antiseptics to decolonize our hand before touching the patient. If we using the gloves, we have to change it. Likewise, so usually hand hygiene, we think compliance is 100%, but we are human. But at least we have to have 80%. So that is, if you think, so in the ward, we'll say example, we in the cubicle, we do the assessment of investigation and clinical assessment of the patient. Then when we are going to next patient, we can't do as such while same hand. We have to hand sanitize. We have to use it, 70% alcohol. That's it. Then, so every movement we take as a movement, 1, 2, 3, 4. We'll say 100 movements. Every movement should be as per the guideline. We have to follow the hand hygiene. But in the ward setup, out of that 100 movements, how the doctor or healthcare worker is following, how many is doing correctly. So it should be at least 80% or more. Ideally, it should be 100%. But when the current practice, we check how many movements they do properly following the hand hygiene. So out of 100, it is 60 means it is 60%. So it is less than the benchmark. So then we have to have sessions, maybe workshop, or maybe train the training, or maybe discussing what are the problems and re-emphasize the requirement to mitigate the transfer of the infections. So that is how it goes. So then again, we allow some time and recheck. That's what really happening. So before to start, big audits, we don't follow much big audits. We set up only 1 or 2 criteria, hand hygiene. We need to engage the whole team and share the work, make life easier, use protocol standards, and data collection properly. Choosing the topic relevant, hand hygiene. Potential benefits must have known standard. Standard should be there. Own area of interest you can follow, areas you can influence. So there are some waiting time for a particular procedure, waiting time for the pap smear, cancer screening, waiting time for the exercise ECG. Likewise, availability of staff, record keeping. Then about the referrals. Are they referring to the subspecialties for that particular care? That also part of audit. Prescribing, investigations. Then aspirin post-MI use. Blood pressure measurements, 5L in those age 20 to 65. Likewise, there are different lot of pneumococcal vaccine is splenectomized patients are significant events because it is much more important. Likewise, we have to get an idea what procedure we are going to assess. Then we have to plan it, decide what to do. Select the topic, write objectives, choose criteria, standard guidelines, methodology, sample, what is the time frame, data source. Are we going to do follow up the patients like prospective or using the medical records? We are going back and assess retrospective. involves stakeholders, those who are in the other supportive staff, maybe other specialties, or medical administrator, the role, and suppliers, and also, if possible, the patients. We have to improve. Objectives to measure. Features of quality. 100% more percentage to meet standards. Difference. Exceptions. Definitions. Clarity about data source. Choosing a topic. Topic should be important. Chronic disease management. Referrals or use of lab services. INR in warfarin. Preventive care. Childhood immunization. Cervical cytology. Pap smear. Prescribing post-myocardial treatment, proton pump inhibitors for surgery, or maybe those who are in gastritis, definitely. So there are examples. You can see, I will share this presentation with you. So there are different examples. So it depends on your choice. And criteria. Audit criterion is a specific statement of what should be happening. A statement which defines a measurable item. We have to measure, like hygiene percentage. Can be used to assess the quality. If the hygiene higher, quality is high. Criteria should be explicit. You must demonstrate evidence for justifying them. Key points. Ensure the criteria is measurable. Asthmatic should have had yearly peak flow. Is difficult to measure. Asthmatic should have had peak flow recorded in past year. Is more practical. Likewise, we need to think the topic, like what we are doing in research, here also, clinical audit, we have to think and go ahead. All eligible women aged 25 to 65 should have had a cervical smear in last 5 years. All asthmatics should have had a peak flow record in past year. Likewise, then about the standards. An audit standard is a minimum level of acceptable performance for that criteria. Hand hygiene ideally 100, but we'll say 80%. So here 80% of women should have had a cervical smear. That is out of in the population in that particular age category. At least 80% of women should have had a cervical pap smear. And then, but those who have an abnormal smear, 100% should have had the action taken. Further assessment. So, likewise, there are a lot of examples. At least 80% of eligible women, at least 60% of asthmatic should have had the peak flow recorded in past year. But 100% of drugs in our doctor's bag should be in date. So, drug packing. Likewise, we have to set a standard. Then method, plan methodology in detail. Keep it simple. So, you go there and observe about the hand hygiene. Allow sufficient time. Share ownership. Cooperate. Carry your colleagues. How to set standards. For that, there are guidelines, journals, opinions. Likewise, we have to take it. Likewise, you can see that's about the, if you having a key idea up to now, that's enough actually. Why we are doing audit and how we are going to do audit. What is audit question? What is the benchmark for standards? Likewise. Then based on that, we can go ahead. All children under 2 years should be immunized against tetanus and polio. Standard is 90% of registered patients under the age of 2 should have been immunized against polio and tetanus. Likewise, there are standards. I think now we have an idea about standards. So planning. So it is teamwork. So you can collect information from the computer registers, review the content of medical records, patients, staff or GPs, data collection sheets. So sampling may be random or systemic. Only collect essential information. Use computers, data collection forms. Be careful of data collection. Choose a topic which does not contain too much data collection to extend this become exhaustive. If it is higher data. So that's why we have to choose one topic, one area, one parameter line. Not like a research. Sample collection, it can be prospective or concurrent, what I told earlier. Sample size, we have to measure. There are sample size calculators. So we may go into the multi-professional, cross-sectional, I mean, involvement of different stakeholders and people. And data should be always anonymous. So there are retrospective, manual, electronic, make data collection as easy as possible. Do not collect unnecessary data. Electronic devices, likewise, Google Forms, Sheets, maybe calculators, likewise apps we can use. Then present in the results. Collect results, analyze results, summarize the results. Present results. It's like almost research like. Use percentages here. So standards, observe results. Likewise, you can see what are the differences. Then we need to bridge this gap. Okay, this gap we have to bridge. 45 should taken into the 470. So it's not easy. It takes time. We need to provide continuous guidance for them, continuous re-emphasize the methods, and also it's a mental game. Like. So it's attitude will change more fun. All patients should be seen within 15 minutes of their appointment, time minimum, likewise. Likewise, there are. So you need to explain why you think the practice didn't meet the standard that was set. We have to brainstorm, do our brainstorming sessions. What reasons are there for practices not meeting audit standards? So once we identify the gap, then we have to brainstorm and also we have to get the data in the inferences analysis and see whether why it is the reason. It's a practice reason. Results have been put down as free text on computer rather than coded, opportunistic rather than free formal recall system in use. So that's common problem to us. Doctors' research. Not all GPs are aware of that practice policy. Not all partners agreed with that policy. That also possibility. Patient research. Patient refusing to have test done. Patients on holiday when test done. So the most challenging state is implementing. Audit can tell you whether changes are needed, but it can't tell what methods to use. So what to do at the practice meeting? Emphasize what has been achieved, what we are proud of. Then what we are, why we, what are we are not proud of? How can we correct any deficiencies? Changes must be practical. How are you actually going to make the changes? Simply saying we have got to do better won't result any changes. What need to be done, what's going to be done, when and how. So just telling people to do things better won't result in change. So fail example. GPs agreed to do serum testosterone in patients that they see who is on Viagra. But this won't be like to pass. There's no symptoms to help. There is no system to help. The GPs were given a prompt card that they could stick on their computer screen as a reminder to do the serum testosterone on any patients that have seen who is in Viagra. One example. So that's alerting us. Then to close the loop, we have to repeat the cycle, what I have told, re-audit, re-evaluate. Audit is continuous cycle. So comments on any improvement that have resulted. Re-audit it. How well did you proposals for change work? If you again didn't reach the standard that you set, why not? Where should we practice go from here? So repeat the cycle. Select or reselect the topic. Same audit cycle, define criteria, set standard, plan methodology, collect, analyze, implement changes, evaluate effects of change. Clinical audit. Observe, practice, implement changes, recommendation, repeat process, set standard. Present audit data, write report, written report. Show how actual practice compasses with the adult measure, how the audit finding related to objectives. Use the following headings to present. Audit title, audit team, data, objectives. So this is the method. Data source, sample, results, conclusion, recommendations, and actions. That's the audit report. So there are instances it can be fair. No justification for choice of audit, no justification of criteria, not having split criteria. Likewise, you can be general lack of evidence, numerical errors, not giving much thought to change to be evaluated, and not being specific enough, not delegating specific changes to specific people. So we have to use the team. Poor conclusion and what the process has taught to. No inclusion for possible source of bias. Reference not properly quoted. So all are bias. I think we have had an idea. Thank you.